Hi, Dr. Chappie is here from Spine Center Atlanta, and we're here to talk to you today about some degenerative condition of the spine known as degenerative spinal stenosis. Now, this degeneration can happen anywhere from the cervical to the lumbar spine. We're going to focus primarily on the lumbar spine today because this tends to be the problem that brings patients to see us. And this is an aging process, just like you might get arthritis in your knees or arthritis in your hips. In this case, the arthritis occurs in the joints of the back. And so just to get a little anatomy, this is a spine, this is the lumbar spine, this is the disc, these are the joints called the facet joints. So what happens with degenerative spinal stenosis, you start to get arthritis of these joints, the disc itself starts to degenerate, you get a collapse down, there's a ligament in there called the ligamentum flavum, it gets thickened or hypertrophic. Now when all those things come together, it causes a narrowing where the nerves exit the spinal cord or it causes narrowing of the central opening. That's hence degenerative spinal stenosis. And stenosis just means a narrowing. In this case, we're talking about the narrowing in the lower lumbar spine from the arthritis of the facet joints, the disc collapse and degeneration, and the hypertrophy of the ligamentum flavum. Now there also can be a disc herniation on top of all this, and a lot of times that's what actually pushes a patient over the edge to come and see us. Now, once you have that, how do we treat it? Well, we always try to treat things conservatively. Physical therapy, anti-inflammatory, stretching exercises. If those aren't successful, then we try epidural blocks. If the pain's coming from the facet joint itself, facet injections or what's called medial branch blocks numb the nerve that goes to the facet. And then if that's successful, something can be done called radiofrequency ablation or RFA. Now, if all those fail and a patient is still symptomatic, then the question is, can surgery be helpful? What would be the indications for surgery? And what would be the operation that would be most likely to help? And what I like to tell most of my patients, even though the MRI scan may show problems at multiple levels, the question clinically is what's most symptomatic. If a patient's having primarily leg pain, then the question is which nerve root is the one that's causing the problem, because that could be treated with what's called a laminoforaminotomy, where you're just burring the opening for the nerve that's compressed. If we have something like that, I like to do what's called a selective nerve root sleeve block by one of our pain docs first. And what that'll do is tell us if it takes the pain away, for instance, at the L4 nerve root on the right, and that's where the patient's symptoms are, the block takes the pain away, then we feel better recommending the foraminotomy or laminoforaminotomy at that level. If the patient's also having significant back pain, then the question is whether or not a fusion should be added to this, much more extensive procedure. But if there's back pain, that might be an option. The other potential option, which is sort of an intermediary between the decompression alone and the decompression and fusion, is a little device we call the Coflex device. It's an interlaminar, this one's interspinous process clamp that actually opens up the facet joints and can minimize facet pain. Now there's a number of these types of devices out there. This is one that we like and use occasionally. To see if this is going to be helpful, you can do diagnostic facet injections at the level you're considering the Coflex. If that helps the pain, then that tends to show that maybe the Coflex could be helpful. So in general, once conservative measures fail, the surgical approach is either a decompression, which means opening up the nerve root, opening up the spinal canal, and then whether or not there needs to be more done as far as a fusion procedure as we talked about, or whether there could be an intermediary type procedure where just a decompression and a Coflex or interlaminar type device could be helpful. The other thing I always tell patients, even though we might work on the L3-4 level today that's most symptomatic, 2 to 3 years down the line, another level could become symptomatic, and then we have to address that. So this basically is a degenerative process, just like arthritis of the knee or of the hip. This just happens to be in the spine, and today we're focused just on the lumbar spine.